Thank you, Parag. So we're going to honor hard work and diligence, which is some of the things that my father really aspired to. So the younger than 40 author, Dr. Vijaya Digge, has written a prospective randomized study, the most compelling and the most difficult kind of study that we do. A prospective randomized study comparing a large console imageless computer-assisted navigation versus accelerometer-based portable navigation technique in total knee arthroplasty. So I invite Dr. Digge to come up and give us his presentation.
Thank you, organizers. I especially thank you, my mentor and my inspiration, Professor Malhotra, for providing an opportunity to present this paper. We all know that total knee arthroplasty is the last resort for the end-stage osteoarthritis of the knee, and which is prevalent around 28% in India. And there is increased demand in TKR because of longer life expectancy and expectation in better quality of life. The main aim of TKR is to relieve the pain, to improve the function of the knee, while improving the quality of life. All these are depending upon the longevity of the implant. Many studies suggest that the longevity of the implant depends upon the component position, alignment of the limb, joint limb preservation. Last but not the least is the soft tissue balancing. The factors which affect the implant longevity are the factors which surgeon keep in mind while performing the surgery, and these are the factors which affect the overall outcome of the patients. So we have many techniques. With conventional technique, we have increased errors, and there are increased outliers in terms of component position and mechanical alignment. To improve these factors, we have advancement in techniques in terms of navigation, PSI, and robotic. All cannot afford robotic, so it's a compromise between the robotic and conventional. We have navigation. Currently, there are two kinds of navigation available in the worldwide. That is a console-based navigation and accelerometer-based navigation, that is handheld navigation. So, as we have in Indian subcontinent, there is a less evidence available regarding which technique is better. So we have decided to perform a prospective randomized study to compare these navigation techniques under the guidance of Professor Rajesh Malhotra. And with the aim of knowing the intraoperative tourniquet time and component positioning, mechanical alignment, and cost and complication involved in each technique, and overall patient satisfaction after the surgery. We have done this study at the Department of Orthopedics, AIMS, after approval from the Institute Ethical Committee, and sample size was calculated with respect to this article, and considering 80% power for the study and alpha error of 5%, we decided to include 94 to perform this study. We included patients who underwent bilateral simultaneous TKR and who gave consent for the surgery. We excluded patients who underwent hip and knee arthroplasty simultaneously, conventional arthroplasty who refused surgery, who underwent revision, and patients with implant, intramedullary implant in situ were excluded specifically for the console-based navigation. Prior evaluation done collecting the demographic data and clinical assessment with respect to deformity and knee range of motion, and functional assessment of the knee was done using a knee society score and Oxford knee score. Radiological evaluation was done taking a scanogram and X-ray of the knee in AP and lateral views. Perioperative protocol, once the patients were included in the study, patients were admitted 1 or 2 days prior to the surgery. Anesthesia was given depending upon the anesthetist and patient choice. Tourniquet was applied from the beginning of the skin incision till the arthrotomy was closed, and all the surgeries were performed by the single surgeon. Wound was closed over a drain, which was removed after 48 hours after the surgery, and blood loss was calculated using a Gauss formula. Standard deviative prophylaxis given to all the patients, and phase therapy which was started in the preoperative continued in the postoperative period. I don't go in detail regarding the technique, but major difference between these two techniques are, in console-based navigation, we need to have a threaded 6.5 pin, which is need to put in the femur and tibia, over which tracker was applied. After that, bony landmarks were registered, then the cut was taken. In handheld navigation, we have a pod, pod and a battery which is attached to the cutting jig, and cut was taken after confirming the alignment. So post-operatively, we assess clinically range of motion and any deformity persistence, and functional assessment done using these scores at regular intervals and at the end of the 2 years. Post-operative radiological evaluation done using a scanogram and a knee X-ray taken in AP and lateral view, and we assessed the frontal and sagittal femoral and tibial angle, and rotation was assessed using a CT scan, which was done before the discharge or at the end of 2 weeks, when patient came for the suture removal. Statistical analysis done using a 14.0 software, and we included 110 patients for the study, but 110 knees, that is 55 patients. 10 knees were excluded after applying the criteria, and then patients were randomized. There were 25 patients in each group, and all the patients were followed till at the end of 2 years, and all the patients were analyzed after 2 years. There was no statistical significant difference between the demographic data between these two groups. However, the striking feature of our study is there is a reduced tourniquet time by 8 to 10 minutes, which was statistically significant comparing these two techniques. However, there is a reduced blood loss, but it was not statistically significant. Clinical parameters was comparable between the groups. There was no statistical significant, and functional assessment was also comparable between the groups. There was no statistical significance between these two groups, and same observation made with the radiological parameters. Complications, we had 3 complications in the console-based navigation which related to pin loosening. Fortunately, by the time it got loose, we got all the bony cuts before it got loose. And with one patient in handheld navigation where the battery life got exhausted. Coming to discussion, where very few papers are available in the worldwide, and there's in Asian countries, I think one paper from Japan and Singapore, and this is the first study in the Indian subcontinent. We have similar observation as compared to previous studies with respect to the duration of surgery and tourniquet time, and clinical outcome and radiological outcome comparable between the groups, and it is a similar observation made by the previous authors. In the recent articles by the HSS, we suggest that the component positioning with handheld navigation is comparable to the PSI, and there is a recent study which suggests that component positioning sagittal tibial slope is better with the handheld navigation. Complication less with the handheld navigation compared to console-based navigation. Cost is definitely it is less. We too have limitations with blinding was not done, inter-observer comparison was not assessed, and to summarize our study, AccelerometerBased navigation gives a result as comparable to the console-based navigation with reduced tourniquet time, with reduced cost and less complication. To conclude, if you want to give any benefit, all the benefit of navigation to your patient with less cost, less complication, less learning curve, ABN is the way.
Hold on. So I'm going to applaud them for a few characteristics for their study. 1, it was prospective randomized. 2, it was powered effectively. 3, they had post-operative radiographs, post-operative patient-reported outcomes, and they also had post-operative CT scans. Right? This is the type of study that makes knowledge better. It's very hard to argue with the science behind this. Anyone would like to argue and challenge him, go ahead, but just remember I'm standing next to him. So the microphones are open. All right, we have his diploma.
I have a question. So this study which you conducted was totally how many cases you said?
We included 110 knees, that's 55 patients. After inclusion criteria, 5 patients were excluded from the study. So total 100 knees, 50 patients, and after randomization, 25 patients in each group.
So are you planning a follow-up study of this further to, kind of validate your conclusions? So is this going to be an ongoing study? Or?
So that's what I have mentioned in the limitation. We need a longer follow-up.
He's already validated a study that's already published, prospective randomized. So this is a validation
numbers,
study.
if you see, will now need to go up to do that. So is that the plan?
Yeah, we are following it up, but with respect to the clinical outcome, I think after 1 year, 2 years, clinical outcome doesn't matter, doesn't differ much. But however, the longevity of the implant, definitely we need to assess, so we need to have a longer follow-up for these.
Okay.
Excellent study. The few points, types of implant is used the same?
No, because console-based navigation we used is Orthopilot, which is from Escolab. The accelerometer-based navigation in India, it is distributed by the Smith & Nephew. So we use Smith & Genesis to implant.
Does it make any difference in this study?
No,
And why?
because implant, it will not give any, the result doesn't matter on the type of the implant you select. It mainly the technique and mainly the balance and the component position. It matters a lot than the implant.
The second thing is the true system, the difference between in the computer navigation does allow you to ligament balancing.
It doesn't allow soft tissue balancing. You need to assess yourself.
The small based,
No, it doesn't allow you.
even the computer.
No, even the computer, it doesn't allow you. But you need to have conventional principles in your mind. Only computer suggests, but it is up to you whether to take it or not.
And maybe this computer, but the other computer, which we use it regularly, you can do a ligament balancing, check it, even the rotation. But this small system doesn't allow you to
small
check even the
system,
rotation as well.
The another limitation
It just
of,
gives you the proximal and distal cut. So what does
yeah.
it make a difference in comparing the two
Yeah, I
studies?
agree with you. The handheld navigation, the limitation of handheld navigation is it doesn't give any suggestion regarding the rotation. It is only the proximal tibial cut and distal femoral cut.
So what's your interpretation of CT scan being done, and how does it affect your study?
CT scan we did in the post-operative period to assess the rotation of the component. We saw that there was no statistical significant, though there were outliers, but it was not statistical significant between these two groups with respect to the component rotation.
The only positive statistical difference that you had in your study was tourniquet time.
Yeah.
So can you please provide us with a critical analysis of why was there such a stark difference, the p-value being 0.0009?
Yeah, definitely. It's a very good question. That's what the main crux of this study. It gives insight into the, it is a quicker surgery as compared to the console-based navigation, because there we need to validate all the bony landmarks, we need to register, and there is a difference when the console-based is set up at the particular distance, you get a disturbance in between. So with this technique, you reduce the surgical time and tourniquet time as such. So it is beneficial for the patients.
So would you be happy to conclude that if you're using an accelerometer-based navigation, it adds to the patient's safety, and the conventional CAS is not safe in terms of surgical time and other complications happening?
Definitely, when you have a less tourniquet time and surgical time, there's a lot of benefits for the patients. And you can see even when a person using a console-based navigation, when he goes to accelerometer-based navigation, there's definitely less learning curve with the accelerometer-based navigation compared to the console-based navigation.
Thank you.
Thank you. So may I request Amar to please hand over a certificate and token cash prize as our appreciation.